what causes resistance after CAR T cells, right? I mean, if you got this, if they're persisting, and sometimes they're not, but if they're persisting, what's the mechanism of escape? Do you know anything about that?
Well, one of the things that can happen is that the cancer cells can actually change their expression of CD19, which is the target. And we know that I think in some ways, if conceptually you can think of cancer cells as like bacteria. So if you give an antibiotic, you'll often see antibiotic resistance. That they're remarkably, there's remarkable plasticity and the ability for these cells to evolve and basically genetically mutate such that they don't look like the cells that were susceptible. And that's true for chemotherapy, and it's also true for immune therapy.
Yeah, I'll add to that. So we know for ALL that resistance can develop through loss of the CD19 epitope that's recognized by the CAR T cells. And the mechanisms for that are starting to be understood. In fact, there can be exon 2 alteration of splicing of exon 2 of CD19, and that leads to an altered CD19. It loses its normal signaling properties, but it no longer becomes visible to the CAR T cell. And yet that same altered epitope also confers survival advantages to those ALL cells. And then recently, Cameron Turtle reported on a second mechanism of resistance in ALL, which is in patients who have an MLL fusion of their ALL. A known resistance mechanism to chemotherapy was also found in CAR T cell treated patients where they switched lineage. They went from an ALL lineage to an AML lineage, and so they no longer express CD19. So those are two mechanisms of relapse in ALL. In diffuse large B-cell lymphoma, we have to do the experiments to figure out why patients aren't responding or why they're relapsing.
So if the mechanism is one mechanism of resistance is modulation of CD19, are we going to see combination or cocktails of CAR T cells targeting other antigens, other B-cell antigens, CD20, CD23? You started off by talking why everyone settled on CD19 as the antigen of choice.
Yeah, I think that people are already looking at alternative targets. CD19 is tough because of rituximab and the heavily pretreatment that the patients will have received, but there's alternate antigens that are on B cells, so you might conceivably get a cocktail of CAR T cells or in sequence against different targets. We mentioned briefly multiple myeloma, and then there's in development CAR T cells against BCMA, B-cell maturation antigen, which is expressed on multiple myeloma cells. So this is coming along. The other way to think about the next step here is to combine it with some of those checkpoint blockade antibodies that we talked about earlier. So combining CAR T cells with anti-PD-1 or anti-PD ligand 1 is likely to be another.
I think the one thing I have to add about that is that I think just like we talked about this issue of one co-stimulatory domain versus the other, and the benefit of persistence versus the downside of maybe overexpansion in the beginning that leads to toxicity. I think we have to all of these studies. It's true that there are a subset of patients that may benefit from disinhibition of their T cell response because maybe those T cells can get exhausted as well. On the other hand, will that lead to more toxicity? I think this is really a critical question.
Absolutely. So it's early days. We need to do these studies and figure out figure out the safest way to administer them, figure out what responses we can expect.